DKA and the insulin drip. So we are new to our Epic insulin infusion computer calculator. So I've heard from a couple of people that they wanted a little bit of a refresher. So here it is. How do you find? I've heard a couple of people, pharmacists, unable to find the calculator. Step one is you click over here on more, and then you star the insulin calculator, and then it'll be saved right here for you. Okay? The pharmacy view is in a flow sheet. It looks like this. It has the same steps as the nurse. I'll show you their view in a second. But it requires the same blood glucose double entry as our last calculator. This is a new feature where we are asking the nurse to please note if there has been a decrease in any form of dextrose since their last entry. I will repeat that. Has there been any decrease in any dextrose source since the last entry? Okay, because if you press that, it will automatically, if your answer goes from no to yes, it will automatically have your ISC. Okay, if you've got tube feeds going and it changes, it decreases or stops, the nurse presses that button and it takes away the vast majority of calls you guys used to get on the old calculator. Okay, does that make sense? We are automating the most common call to pharmacy. But the wording is new and has been a little bit confusing for nurses. So we are about to send out a nursing survey to see if this current wording, which says nutrition on hold or decreased since last entry, and giving them example of any continuous dextrose source, versus since last entry has nutrition decreased, and having those same ones. Okay, but I want you guys to understand, no matter what that wording says, the entire purpose of that button is since the last entry has any form of dextrose changed, because we need to simultaneously decrease the insulin infusion rate to go with it to prevent hypoglycemia. Does that make sense? Any questions about that button? Okay. Yes.
I don't have a question. I just want to. This has come up multiple times on my floor. The nurses keep saying yes if the patient's been NPO like for 8 hours, and they're like yes, 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 yes. So just make sure that doesn't happen. Yeah. Let's make sure that doesn't happen.
Right. It's since last entry.
They failed to read that part.
Yes, that's why we're considering two different changes. Then it will spit out your dosing recommendation for drip rate or bolus rate. It's got your unit-specific goals, easy access right there for you. This is the nursing view in the MAR. It has the exact same information, the dual blood sugar entry, that question, followed by their recommendations and unit-specific goals. Okay? Then here's the pharmacy-specific functioning, pharmacist tools. This is where you guys would go to adjust the ISC if you needed to. But again, we've taken out 95+% of the reasons you guys used to get calls for ISC resets. So this button shouldn't need to be pressed very often. And if it does need to be pressed, we need your comments of why you did it so we can figure that out. Okay? And we can't read your mind later. Then there's this new function here for an ISC. So before, in our previous calculator, there were two main reasons why we would call you guys and say, can you please, please, please reset the calculator every hour or two? Okay? One of these was for those super, super, super sensitive patients who lived beyond our lowest ISC. Okay? These are our type 1s with end-stage renal, not the majority of type 1s. Okay? There's about 4 of them in our system. So they're very specific patients who are extremely sensitive. And we would call you guys. We would usually have to put them on dextrose to bump their ISC up a little so that they even exist on the spectrum of ISCs that exist in our calculator. And then a lot of times you guys would have to manually reset. Okay, those are the 4 patients this button is for, not just plain type 1. Our regular old calculator works for most patients. Okay, those who are particularly sensitive, you can use this button, and it's going to increase their increments. Instead of by 0.01, it's 0.005, and then it takes their ISC down to a new existence. I think of 0.0005, something like that. It's really low. Yeah. Okay. Any questions about the use of this button? 4 patients, Miss Anita is one of them, who visit Hillcrest, who comes in from her SNF every 2 to 3 months in DKA. Okay. Then, this function, okay, this is the other reason we would have to call you and say, can you please reset the ISC every 1 to 2 hours all night long? So this is for our patients who have prolonged DKA or HHS that has not resolved in a typical time frame. We're going to go over that in more detail, but this is for the patient who needs to remain with a blood sugar in the 200s for 2 or 3 days, okay, because either their DKA is not resolving or their HHS is not resolving in our typical, 6 to 12, 14-hour time frame. Okay, we do not press this button in all patients with DKA or HHS. Make sense? Okay.
And what should we be adding if we're pushing that button? What should we make sure?
Oh, that's what we're going to get into. Okay. That's what this whole talk is going to be about. And then anytime you press any of those things, please make a comment of why you're doing that. Okay? Any questions?
And if it was like a specific physician that you wanted you to hit the button, put their name in. To be honest with you, Dr. Kulasa would probably be about one of the only ones that should be able to tell you that.
And there'll be a reason. I'll give you a reason. But most of it's programmed in there. Okay?
Is that what it says right there at the bottom? Say pharmacy comments?
Yes.
Yes, pharmacist comments.
Did we make this a required field? No. But it is really required. Okay. So now we're going to get into DKA because I want you guys to really understand DKA, why it exists, okay, how it's treated, and how to utilize this tool, which is the infusion calculator, to manage DKA, okay? So we're going to start with a case. 45-year-old obese gentleman comes in, 6 months of increased thirst urination, worse over the last 2 to 3 weeks. 3 days before admission, he goes to his primary care doctor. They told him he has diabetes, and they started him on a sulfonylurea. Then he comes into the ED because he doesn't feel any better, and these are his labs. Does this patient have DKA or HHS? So what is DKA? DKA is absolute insulin deficiency, okay? When you have absolute insulin deficiency, you have no insulin around. If you guys remember from previous talks, one of the main purposes of basal insulin is to suppress glucose and ketone production. Without insulin, your body cannot utilize glucose as a fuel source. Then you start breaking down your fatty acids, and a byproduct is ketones, okay? So no insulin circulating around, you start making ketones. Ketones are unpleasant, okay? You turn your body into this acid state. You get abdominal pain, nausea, vomiting. You get this hyperventilation because you're really trying to breathe off all that acid. You get dehydrated because your sugar's so high. You cannot pee out sugar cubes. Therefore, it takes all water with it. And you're peeing out syrup. You get really dehydrated. Your brain turns to a little raisin, and you become altered. Okay? That is DKA. Usually, something pushes you over into DKA. Okay? A lot of stressors, some sort of infection, heart attack, trauma, emotional stressors, alcohol, not taking your insulin, especially if you're type 1 and you make no insulin, then you don't take it. You get some ketones, and then some drugs. Okay, this is the smorgasbord of lab abnormalities you get with DKA. Obviously, your glucose is high. You get electrolyte abnormalities, particularly your sodium is usually low to normal because of all the sugar in your blood. It's pulling all that water into your blood and it's lowering your sodium. Potassium, okay, with the acid, potassium is switching with the hydrogen, so potassium's going out, hydrogen's going in, so you get hyperkalemia. BUN creatinine are often elevated because there's severe dehydration. Okay, CBC can be elevated from the stress or the infection that precipitated the DKA. You need to have the K component of the DKA, so either serum or urine ketones are positive. And then you always want to check your osmolality, and that's your calculated effective osmolality, so you can differentiate DKA versus HHS. Your ABG and your bicarb to see if you're actually acidotic. Make sure you're looking for a mixed picture, because a lot of times your pH will be normal, but your bicarb will be really low and you're just compensated. And then, of course, you need to not miss the precipitating factor.
Do they always get the osmolality?
It's calculated.
It's calculated.
So even if they check an osmolality, that's not the number you want to go by, because that includes your BUN, which is freely permeable. So you want your calculated effective osmolality, which conveniently lives right here below the diagnostic criteria. It's going to be your glucose divided by 18 plus your sodium times 2. Okay? And that's what your brain is seeing. So here is your diagnostic criteria for both DKA and HHS. Okay, for our patient, he had a blood sugar of 480. He had a pH of 7.28, a bicarb of 15. Urine ketones were positive. Serum were elevated. And here's his calculated effective osmolality. So you take sodium times 2 plus glucose divided by 18, and that's 287. Okay? So, does he have DKA? Yes? Absolutely. Okay? How do we treat DKA? What's step 1? Fluid. Step 2. Fluid. More fluid. Step 3. Fluids again. Okay, these patients are so severely dehydrated. They need to increase your circulation before we go moving things around. Okay? Fluids alone are going to lower your sugar by several hundred points. So you want to make sure there is at least 1 to 2 liters of fluids on board before you even consider insulin. Okay, if you start moving all of that glucose from the blood to the muscles, which is what insulin's going to do, and all that water is going to follow, and you don't want to have circulatory collapse because now you're taking everything out of the blood vessels. Okay, so fluids, and then what's next? I'll give you a hint. It's not insulin. It's your electrolytes, okay? Particularly your sodium, potassium. Then we can consider insulin, okay? That potassium, remember, is going to start moving. You do not want it to move until you're ready. So make sure you have your potassium replete before you start adding insulin. And then, of course, bicarb if your pH warrants it and you don't want to miss your precipitating factor. Okay? Fluids, electrolytes, then insulin. Okay.
When would you push bicarb?
It's usually 6-8. 6-8 to 7.
Okay.
Yeah.
Any
Okay.
particular bicarb on the,
Pardon?
Any bicarb on the CMP? Like number like less than 6?
No, it's pH.
So you go straight on pH.
Straight by pH. Okay, so I want you to understand in DKA the role of insulin. Okay, why do we use insulin in DKA? What is it doing? So insulin is the workhorse. It is the entire treatment of DKA. You got to do your fluids, right? Because we don't want to have circulatory collapse, okay? But insulin is the guy who is turning off your production of ketones, okay? It is turning that off, and it's cleaning all the ketones up, okay? So insulin is the one doing the job, actually cleaning. If you look at this brush, that brush is insulin, okay? It is doing all the cleaning. It is doing all the work. But in order to run insulin, we can't just turn on a garden hose of insulin, right? What's going to happen to our patient? Yeah, their blood sugar is going to tank, okay? So we have to have dextrose to run that insulin. So the water, okay, is powering our insulin. That dextrose is powering our insulin drip, okay? So this insulin infusion is powered by your dextrose. Does that make sense? Okay, so our patient comes in DKA, we turn on our little car wash here, right? Okay, our gap, it's closing, closing, closing. If it's not closing fast enough and you want to push up the power, okay, we want a higher car wash. We want something more intense. We want to clean, scrubbing bubbles, more, more, more. What do we need to do to turn up that car wash? Dextrose. It's powering the entire car wash, okay? So we're starting with our D5 at 200. How do we turn it up? 250, 300. Okay, you keep cranking. If it's not working and you're not getting the effects you want, your gap is not closing or it's not closing as fast as you want, turn up the car wash. You have to turn up the car wash using dextrose. Okay, so you push it up 250, 300 if you're getting into volume problems, or if you want it even higher than that, go to D10. Okay, we got super car wash. That is how you are going to clean. That is how you are going to clean up your gas and remove those ketones, your gap. Okay, does that make sense to you guys? Okay, so moving on. Once your gap is closed, okay, I think of the gap as like Velcro. You're closing it, you're using your car wash, closing, 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 closing. All of a sudden you have one gap closed, okay? What's going to happen if you stop that insulin and don't do anything else? Yeah, your sugar's going to go skyrocketing because you didn't touch that D5 and it's going to bust back open. Okay, so you want to run the car wash until your gap is secure and that Velcro is overlapped at least twice so that if the patient eats and they don't get the proper insulin, if the intern forgets to turn off the dextrose, something happens, their gap doesn't bust back open. Okay, then we have to start all over again. Does that make sense?
You said twice. Is there an interval? 4 hours?
It's usually every 4 hours they're doing it. Yes. Okay? So the other thing I want to know is for type 1s versus type 2. Okay? How do you get DKA? Type 1, it makes sense, right? They don't make any insulin if they don't take it, or they're really uncontrolled and they get some massive infection or heart attack. It just is above their insulin's capability and they can go into DKA. Okay? How does a type 2, because I just told you DKA is absolute insulin deficiency. How does a type 2 go into DKA? No.
Beta cells tire out.
Absolutely. Absolutely. So it's usually beta cell toxicity. And that's going to be a type 2. You'll usually see their A1C greater than 10 to 12. And then they have some precipitating factor that throws them over into DKA. So their beta cells that are on this treadmill, running, just go kaput. Okay. So that's how a type 2. Can you think of any other way a patient without diabetes could get DKA?
Steroids.
But they have beta cells functioning. Pancreatitis! Absolutely. Okay. Total inflammation of this pancreas, and these beta cells stop functioning. They die or they're toxic. We don't know. And only time will tell if their beta cells wake up and start working again. But absolutely, pancreatitis causes DKA, and that's just telling you the level of damage that is going on in that pancreas. Okay, does that make sense? All of these patients, type 2, type 1, pancreatic, If they're coming with DKA, that is telling you they're absolutely insulin deficient and need to be transitioned to insulin after we treat them. Make sense?
So even though like normal glycemic, but they have pancreatitis and look like to be in DKA, you'd still start on D5 plus an insulin drip and just bridge up, and their beta hydroxybutyrate would be elevated in this situation.
Yep.
Okay, so you diagnose this off of beta hydroxybutyrate.
The DKA part?
Yeah.
Oh, they'll be hyperglycemic too.
I've seen a euglycemia DKA.
Okay, so how do you get euglycemic DKA?
I don't know.
Like the
really
outpatient meds, like the.
Yes, absolutely.
So, like,
There was one of the outpatient classes of medications, the SGLT2 inhibitors that are causing glucoseuria. So they're masking. So you take a type 1 in particular who's on an SGLT2 and they stop taking their insulin, but these SGLT2s hang on board for a long time, like a week. Okay, so then they still have their SGLT2 on board. They're going to make ketones because they got no insulin, right? But they're going to still be peeing out all the sugar, so it can mask the hyperglycemia. Okay, make sense? Okay. Here's your algorithm for DKA. It's on WebRef. You can study it, enjoy it. But it's all those steps we just talked about. Fluids, electrolytes, insulin. Okay, complications of DKA. Obviously, we can deal with some hyper or hypoglycemia. Hypoglycemia is particularly what we'd like to avoid. Hypokalemia, okay? With all the movement of that potassium, you want to make sure it's not going too fast. Cerebral edema, okay? That's when we drop our sugar too fast. Remember, when all that sugar is in the blood, it's pulling all the water, right? Your brain turns into a little raisin. And if you lower that sugar too fast, okay, and then all that water is going to go back into the brain and expand it too fast. We want to make sure we don't cause cerebral edema. It is bad, okay? We want to gradually bring that sugar down. We want to keep it in the 200s until our acidosis is resolved and our gap is closed. Then it is safe to bring it back down, okay? Here's an example of what not to do. This is a patient whose blood sugar was in the 400s, and 4 hours later it's in the 40s, okay? The usual reason for this is starting insulin before they're adequately hydrated, because the computer doesn't know you're simultaneously giving them all this fluid that is also working to lower their sugar a couple hundred points. That's why it's important to make sure they have a good 1 to 2 liters on board before you start running any insulin, okay? And then you stop it, they go back up, give them more insulin, they come back down, badness, okay? Please don't do that. Okay, HHS, this is hyperosmolar hyperglycemic state, sometimes called HONK, not hypothenor-Hammer syndrome, which I see on the billing all the time. But HHS, okay, this is a relative insulin deficiency. DKA is absolute. This is relative. You've got 1 or 2 insulins still roaming around, okay, so you're not making the ketones. But you get significantly less insulin than you need. So here you don't get the ketone production. Therefore, you don't get the GI symptoms. Therefore, you don't seek help very fast. And they sit at home and they become these raisins. Okay, they're peeing out all this sugar and all this water, and they get super, super, super dehydrated, and they come in altered. There's a higher mortality rate in HHS than DKA because of that delay in diagnosis. Your symptoms are similar to DKA, but without the GI symptoms because there's none of the ketones in the acid. They come in altered of some sort. It can actually mimic a stroke with even focal neurosyndrome symptoms, but usually it's more general. And here's the diagnostic criteria. High blood sugars, and it's down to your H and your H, hyperglycemia, hyperosmolar. Here's the same diagnostic criteria that live in WebRef for you to reference anytime you want, 24/7. The same treatment algorithm also lives in WebRef. Just know that we have these order sets that exist for the providers. Okay, there is an admission and there is a revision order set for DKA that has all those moving parts right there in it. The admission version also contains all the generic admission orders, and then the revision is just the specific DKA. So halfway down, it gets into specific DKA HHS. Fluids, all the different fluid options we just talked about. Okay, just plain LR or normal saline for your initial boluses, then adding the dextrose to it, putting some potassium in there if you need it, depending on which ingredients you need. Okay, all those options are there. It even comes with an order for the nurse to call the provider when that sugar is getting to about 200, 250 to remind them to add dextrose, okay? If they don't use the DKA order set, they don't get that reminder. And this is one of the biggest failures we have in DKA treatment. So they could use your assistance and reminding that when that sugar is coming down, 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 okay, and about 200, 250, we turn the dextrose on. Okay, that keeps the car wash going. It keeps everything cleaning. Then your drip is going to go back up. The insulin's going to go higher. Okay, it's going to clean, 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 and it's going to slowly be trying to bring you down to your, if you're in the ICU, 100 to 150 or IMU 100 to 180. When it starts coming down again to 200, what do? Turn it up again. Okay, you keep cleaning, and then you'll watch your gap close. Usually in type 1s, it takes 6, 8, 10 hours to close. Type 2 can take longer because, again, it took them a lot longer to get into DKA and really make those beta cells toxic. It can take longer to treat them.
Is there a recommendation on, you say bolus, and fluid, like a mils per kilo, like in sepsis 30?
A lot. Just put a lot.
Just a lot.
Yeah.
A lot is.
It depends on the age and the comorbidities. These young people, like 6, 8, 10 liters a lot of times to rehydrate them. I just usually bolus until they start peeing. And it's the color you want, the light lemonade, not the dark beers. Okay, that's your order. It gives them guidance on which to pick. HHS versus DKA. So because that HHS, remember their brains are like raisins, okay? We really start the dextrose at 300 and we keep it in the 200s until that brain is happy. It can take much longer to treat HHS. Real HHS is pretty rare, okay, if you're actually using the right criteria. And then, of course, the bicarb, the potassium, all with guidance, are all in that order set, and then the insulin drip per our standard protocol. And then the labs if they missed it. And there's also order sets in the ER, so they should be doing the same management there.
When did this order set go live?
Like almost 2 years ago. Yeah, it's awesome. It's used all the time, isn't it? So, resolution. When is our DKA or HHS resolved? Okay. Resolution of DKA, you want to run that car wash until your gap is closed and your acidosis is resolved. Then it is safe to turn down your dextrose or off and let it go. And I would say to make sure your gap is closed ×2 to really secure that gap. Okay? Resolution of HHS is when their mental status is back to baseline. That can often take a day or 2 or 3 or at least 2 days to figure out what their baseline was. So those are the cases that we might have to use that button, which we'll talk about in a second. Okay, here's an example of a case from today. Oh, yeah. So this is a patient who came in DKA, met all the criteria. Over here was started on fluids, insulin and dextrose, D5-LR at 100, okay? Blood sugars are coming down, 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 remains on the D5 at 100. So you see here, the blood sugar somewhere over here hits that 200. So right about here, we probably should have turned up the car wash, okay? When you see that blood sugar getting down to 200, 250, turn it up and really keep that car wash going, okay? But luckily, here the gap closed. Okay, but we probably should have increased our dextrose there. Okay, so once the gap is closed, it is okay to let things ride, and when it's closed times 2, then you can turn your dextrose off or down. Okay, make sure the nurse pushes the button that says, hey, I'm turning it down, so that the insulin can decrease accordingly. It is safe when your gap is closed, preferably times 2, to go ahead and decrease both your dextrose and your insulin. And then you just can use it like a regular insulin drip and find out what their requirements are. Does that make sense? Any questions about that? Okay.
Why did you pick 50?
Why 50? So 50 is my borderline of nutrition. That's where it's kind of that buffer. This patient had pancreatitis, and she was going to be prolonged NPO for a long, long time. I didn't know when she was going to start eating. So after about 24, 48 hours, you deplete your glycogen stores. You're at high risk of hypoglycemia anyways. So I wanted to leave it on at 50 just as a little buffer because I didn't know when food would be in her future.
From the ED yesterday, last night.
Yeah.
That's what I was like, I'm really good sugar. It's only 219.
Fine.
So,
and a non-diabetic.
I mean, you don't know an A1C, so
she is also an alcoholic, so she could have a big component of AKA as well. DKA is not the only reason to have ketones. You've got DKA, AKA, and starvation, ketoacidosis. So a lot of euglycemic DKA is really AKA or starvation. Yeah. Okay, so here's another example that came up. This is a patient with type 1 with DKA, came in, met all the criteria, blood sugars really high, fluids, electrolytes, insulin was started here, dextrose was started, we're running here. And then somebody decided to press the button, the 200 to 250 button, okay? So what is that 200 to 250 button going to do? So we're taking our goal range from 100 to 150 if we're in the ICU, or 100 to 180, right? So the computer's trying to pull the blood sugar down there, and it's going to keep increasing the insulin to get that sugar down there. If all of a sudden you change your range to 200 to 250, what is the computer going to do? Decrease the amount of insulin. Is that what we want to do in treatment of DKA? No, absolutely. So anytime you push that button, say you've done your turning up the car wash 2 or 3 times, okay, and now you feel you are in the prolonged DKA and you want to use that button. What do you have to do when you press that button? No. Increase the dextrose. Absolutely, you've got to increase the dextrose, and that way it'll keep your insulin rate going, but it won't be continuously pulling it down below 200. Does that make sense? So never push that button without simultaneously increasing your dextrose.
So during that time when they're 200, the goal is still, for ISC changes, will still be below that. Mm-hmm. So it will continue to increase. So if that's the case, we just sort of ignore those. We want the increase, but we also want to increase the dextrose by 50 cc's an hour, and then we'll see what the next one is. And if the insulin goes up, we should continue to do it if it's still trending down.
Sorry, I lost you.
Sorry. So let's say it was like 211 or something like that. And we should increase the dextrose from 250 to 300, or from like 75 to like 125 an hour, something like that, right?
Well, hopefully it's going faster than that.
Yeah,
it's DKA.
Okay, sure.
But yeah, we're going to go 250 to 300.
Okay, 250 to 300, and then after that, let's say the next one is like 180. Then does that mean that I should have turned the dextrose up higher? I mean, how would I have known?
And are you using your 200, 250 button, or you just...
No.
Okay.
No, just going as is, because that's not the goal, and so the IC went up, and because of that, I'm simultaneously giving more insulin, while also trying to give more dextrose at the same time.
Right. It just means you can keep turning it up.
turning up the dextrose.
Dextrose.
Okay. So the next move would be turn up the dextrose, still
More.
leave the calculator.
Or switch to D10. Yeah, the calculator, let the calculator do its thing. You shouldn't have to intervene in there, because if you have the ISC, it's going to have the insulin. Again, turning off the car wash, which is the exact opposite of what you want in DKA.
So
Turn up the dextrose.
Is there a max amount of dextrose per hour? Because I've gotten pushback before for recommending like 300 mLs per hour. Like, no, we can't do that.
It's the volume is the problem.
Okay.
So no, there's no max
so
amount of dextrose.
concentrate it, like to D10.
Mm-hmm. Exactly.
We've gotten like a lot of pushback
From who?
those recommendations.
We may need to educate them. I have educated them, but teach them about the car wash, and just it doesn't make sense. You got to keep turning it up to close it. Okay, if you turn the insulin down, you're turning off your car wash or turning it down. There's nothing particularly wrong with it. It's just going to make it slower. You could do use that handheld car wash brush and do the whole car. Okay, it can take a little while longer. Make sense? Okay. All right. So here's our friend. So you can see here when they push that button. Oopsie. When they push that button, it decreased the insulin rate, and you can see the gap. It eventually still closed over here, but the answer would have been to turn up the car wash. Okay? Once your gap is closed times 2, you can absolutely transition to sub-Q insulin if it's the appropriate time of day and not 2 a.m. Okay. Second case, 57-year-old male with type 1 diabetes with neuropathy, retinopathy. He's on an insulin pump found down at the rescue mission. Here's his vitals. He's altered, uncomfortable, moaning, dry emesis around his mouth. These are his labs. What does he have? 1156, pretty high. 6.93, pretty low. 3, pretty low. Beta hydroxybutyrate, greater than 83, legit. Calculated effective osmolality, 358. So what does our friend have? Yes, both.
Wow.
That's pretty impressive and pretty rare. So here, he is a type 1, okay? Which do you think came first, the DKA or the HHS? Which one? How many say DKA? No one? I heard several DKAs. How many say HHS? All right, it's got to be the HHS first, right? Because the DKA is going to get really sick and come in. So the DKA, the HHS, they get really, 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 really dehydrated. He probably got altered, passed out, his pump fell off. And then he came in with DKA as well. Either way, treatment is the same. Excellent. And here's its course, okay? So you do all those things, we end up here. Our DKA is resolved by right here. Our gap is 15, but our HHS is not. He is still altered, and HHS takes a while, okay? This case occurred before our new calculator. So the pharmacist here, for 2 days, had to go in and reset that ISC, okay, right here. All 2 of these days. Now we have the button. This is the case you would use that button. And the DKA is resolved. We're just waiting for the brain to catch up. Okay, and that will prevent you guys from having to go in and manually change that every 2 hours. Does that make sense? Okay, that's it.
So like in a patient that no longer needs the 250 and you uncheck that button, should they still keep running the dextrose about the same rate until we see how they respond? Because once we uncheck it, their insulin rate would also shoot up with a low goal.
So what are you trying to do after that point? Because the whole point of running them up until now has been to resolve the DKA or the HHS. So now that both of those are resolved, what's the point of keeping them on the drip?
Is to get them to like normal.
Yeah.
Within goal.
So then you can turn off your dextrose. You can uncheck that box and let the calculator do its thing. Okay? And it'll tell you then what their basal rate is that they actually require to then facilitate a proper transition to sub-Q insulin. Make sense? Which is really nice, especially if it's in the middle of the night.
If you turn that dextrose off, then you would also have to hit that yes.
Absolutely. Absolutely. That's huge.
That, right?
Well, it would
Or we
really
talk with
help
nurses.
to remind him or her. Really, because that button is new. You guys weren't getting the phone calls anyways a lot of the times. So we want to make sure that is being done appropriately. So whenever the opportunity arises, always communicate with the nurse. Hey, we're going to be turning down the dextrose. Push the button when you change the rate.
When you say the button, just make it clear for everybody.
The nutrition on hold, yes, button or decrease.
I had a case where a patient, the hypokalemia was pretty significant to the point where they had DKA changes, and they were running the insulin drip, and it was going fine, and then they held it. The physician went to bedside and just said, "Stop the insulin drip," and then I noticed it was charting at 0 for a while, and the K went down to 2.9, and then they had some EKG changes, and then nephrology came by and decided to dialyze the patient. So during that time, the dextrose was still running, the insulin drip was off. And
So what's going to happen then?
yeah, well, obviously they were going to go back to DKA. Well, they were still in DKA, so it was still, their anti-gap was still open. So I told them to shut off the dextrose, but they were very hesitant to restart the insulin. I asked them to run it at like 0.5 units an hour, and they had agreed to. And then I spoke with Brittany about it, and it was essentially like they were just really hesitant to turn it back on. They said that the patient already had to turn the drip back on. So what could I have done?
What was their hesitation? Why were they hesitant?
They were hesitant because nephrology had recommended that they check the potassium first. So according to the guidelines, is there any threshold where you would have stopped the insulin drip and the dextrose and just have waited?
You can absolutely do that, but you can't. You got to stop them both simultaneously.
Yeah. So we ended up stopping them both.
You got to pause the car wash.
They were checking every 6 hours. No, they were checking every 4, but they wanted to wait 30 minutes after dialysis. So they were currently in the dialysis session. And so during that time, they said we have 2 more hours that we need to go until we check the K. And then at that point, if it's above 3.3, then we will continue with the insulin. So.
But they're making their problems all worse in the meantime by running dextrose without insulin. If you're going to pause one, you got to pause the other.
Right. So I did get that pause, but was it okay to have both of them off for that time period then?
Yeah, because that's the same reason why you don't start the insulin before your potassium is above 3.3. Because you can go into fatal arrhythmia. That's bad.
Right. So some reasons to shut off the insulin drip regardless would just be like hypokalemia.
But pause it. Let's pause it. Because if you discontinue it, then we never remember. But you want to pause the whole car wash.
Okay.
Treat the potassium and then turn that car wash back on with potassium in your fluids, because that is an ongoing problem. They are total body deplete. We're just shifting.
And then I think when I spoke to Brittany, she brought up an interesting point about if they're dialyzing already, then technically I wouldn't have had to shut it off, the insulin drip off, because they are neutralizing the potassium anyways. So they're trying to bring it up with it.
They are, but they're also correcting your acidosis.
Yeah.
So that is the car wash.
Yeah.
That is another form of car wash. So that's why that dialysis makes it safer for you to turn off both.
Okay.
Because they're in a different form of car wash.
Okay.
Okay, you can treat DKA with dialysis alone, but you're not doing anything to the production of ketones. You're cleaning it up, but you're not turning it off. Yeah.
Sorry. On the first of the labs there, what would be your initial fluid of choice for this patient? And at what point would you start insulin with a K of that? Would be after you give supplement with IV times a couple hours, and then
fluids. Probably normal saline. Most of that comes from dehydration, though.
Okay, so even
the hypernatremia is from. If you look at your algorithm for treatment of sodium, it's from a lot of it's from dehydration.
Okay.
Or you can bolus. You can do the half normal, just aggressively.
Half normal.
You just got to keep an eye on it, but most of it's from just plain old dehydration.
Okay. If you're bridging a little bit, I mean, would you give them some? I guess 7.14 you would give them. Okay.
Less than 7.
Yeah, the data on bicarb is not fantastic, so.
We gave it to Lee last night.
It's just for fun.
It was her bicarb was 6.
It's okay.
Oh yeah, 7.2 per
That's
pH. So in that case,
medicine.
she's basically like killed all her beta cells.
Or stun them.
And so then we give her the insulin and then kind of see how she does at some point. Stop.
Yeah, or we were really treating AKA if her sugar wasn't that high. And a lot of it will be dependent now.
So how did you come up with glargine of 8 on her?
Let's see.
Yeah, what's the minimum glargine dose you give?
1.
You give 1 unit of glargine?
Huh?
You give 1 unit of glargine?
Can you? Should you?
No.
2 different.
It sounds awful for the patient. So no, but there was an order for 2 yesterday. I told Doc no.
The lowest I've seen on a patient is somewhere around 4, 3 or 4 once a day, and that's going to be your type 1 end-stage renal, okay? That insulin's going to circulate for 2 or 3 days, so that 2 is really 6, right, that the body's seeing.
It's really worth it to stick them just to a sliding scale. Like,
Will you tell their body when they become DKA without it?
It's so bad.
There are patients. And most of those patients go to pump.
For type 2, you wouldn't necessarily need that glargine. I agree with you. But a type 1, you have to get the glargine, so that's there's no choice.
So this patient, we ended up putting on dextrose at 50, and her insulin drip rate came down to about 0.3.
Okay.
So that's one way to tell.
Artificially.
Or even this morning,
Yeah.
we were doing averaging, and it averaged out to about 0.81 units per hour on dextrose, which is your total daily dose. So that's still about 8 to 10. We went on the conservative side because we didn't know if she was going to eat. Plus, we want to see if she becomes hyperglycemic or not. So you want to be a little bit more conservative. It's a way to hedge and see, are we going to, we want to keep our patient out of DKA, so we don't want to have absolute insulin deficiency, but we want to see, too, if she's going to become hyperglycemic.
So you want to consider pancreatitis like a type 1? Because their beta cells burnt out.
Say that again?
You want to consider like a pancreatitis that has a DKA like a type 1?
It is, yeah. But you don't know if it's permanent or temporary. It's we call it pancreatic diabetes. So anybody who has a Whipple or chronic pancreatitis that leads to it's kind of like type 1 but not autoimmune.
So once you see that they start becoming hypoglycemic, that may be an indication.
Hyper.
Or hypo, we can start taking off the insulin.
Yeah, I'd be surprised if she became hypo, because again, if she has a functioning pancreas,
it would be.
Yeah.
You were saying in your experience it's been a couple weeks by the time that.
Yeah, I was like, how do you know?
Yeah, a lot of
It's
times.
not like a day or like a couple hours.
Unless she wasn't really in DKA in the first place. Because she wasn't that hyperglycemic. That maybe it was all AKA. Any other questions? But if it was truly from pancreatitis and it was true DKA, yes, it takes several weeks. Usually we would send her out on at least a basal insulin to hedge and keep her out of DKA while she's healing.
Anybody else have any questions?
So, how long do you want to be on the drip. Right?
For
So the common thing that I think we get at pharmacists are, oh, my gap's closed, I want to transition off to insulin drip.
so ideally we want gap close times 2 and a reasonable time frame. Okay. Once your gap is closed, it gives you time so you can bring the blood sugar down to normal and use your drip to find out your blood sugar rate. You can even do it with the dextrose. It's just a little bit more tricky, but we want at least 6 hours of stability of the ISC and your gap closed times 2 and not the middle of the night. Is that too much to ask?
At least like 8 hours.
Yes. Considering we need 6 hours of stability and it's going to take you a good 6 to 8 hours to treat the DKA, when you're still bringing that sugar down and you're running that dextrose to close that gap, I mean, that's all correction. That's all, car wash insulin. You want to find out what the patient needs outside the car wash, or at least with a semi-stable car wash.
Does the order said do Q4-hour cam panel?
Q2 or 4, depending on ICU versus IMU.
So you'll get a lot of pushback about, well, no, we got to get them off the floor or get them out of the unit or whatever. You really have to script your response the right way and say, hey, but we don't know what they need. And then they'll say, oh, we'll just put them on their old regimen. I'm like, that's obviously what got them into DKA in the first place. So you don't just say, hey, give me a couple more hours.
Yeah, or transition them off on the drip. Transition them out of the unit. They can absolutely. The biggest thing I hear from ICU is they can't go to the IMU on an insulin drip or Q1 hour finger sticks, and that is absolutely false. Every ICU or IMU here can run the insulin calculator as written. Their goal is a little different, 100 to 180, so they're more likely to be in Q2. But absolutely, they can leave on an insulin infusion. And it is a better gift for the receiving medicine team to receive a patient on infusion getting stability for a better transition than it is to package them with a bad transition that's going to bust open their gap and then they're going to have to treat DKA all over again. We can get the patient out of the hospital a lot faster with a couple more hours. But they don't have to stay in the ICU for that.
And when you actually go to hit the transition button in the calculator, you have to have at least 4 blood sugars within range before it will actually spit out any recommendations. So that's one of the things for you guys to also remember.
When you push the button and it doesn't give you anything, it's not broken. Yeah. It's an inappropriate time to transition.
Nothing.
Sliding scale. It's a sliding scale.
It won't say that.
Yeah.
Oh yeah, that's what it said this morning.
Correction only?
For this.
Oh, because she didn't have diabetes.
Well, we didn't know, but we.
The 295, 2 less than 100.
Well,
you put in
an A1C of 9, I think, or 8, because we didn't know this
We
morning.
were waiting for it to come back.
Then it wouldn't have
We
told
were
you
just
correction
guessing.
scale only. Couldn't have. That's broken. We need to know about that.
You broke it.
If your A1C was above 9, or it was above 6, yeah, we need to know about that. I shouldn't do that.
Well, we can look at it after.
Any other questions? La Jolla? Any questions?
Side topic.
Yes.
Insulin question.
Yes.
U500, how you love it.
Uh-huh.
So say
I
a
do.
patient comes in overnight or comes to ED and they're in U500. Would you just decrease the dose by 20% if you're going to give them regular? So say they're on 300 units at night or something. I think that PowerPoint said decrease it by 20% and do that with the regular.
Minimum 20%. I usually do 50.
You should do 50%, just like half of this.
Mm-hmm.
What was the question?
Oh, for patients with U500 that you're converting to U100, how much do you decrease their total daily dose by? And I typically do 50% to start, just because they don't have their home diet in the hospital, which is usually how they bought themselves U500 in the first place.
Would you ever switch them over to an MPH? Because So,
Never.
nothing.
No, always U100. Lantus, Humalog.
At what point would you start splitting the Lantus dose into Q12 dose?
I start splitting the Lantus dose into Q12. Three reasons. Okay, one, if you notice the Lantus is not lasting 24 hours, they start becoming hyperglycemic for no reason, 2 to 6 hours before their Lantus dose is given. Okay, then I'll split it. If it peaks, we have a couple of these super sensitive patients that tend to go low 2 to 3 hours after their Lantus dose is administered. Okay, if they have a little peak, then we split it. But usually it's a volume. The package insert, I think, says somewhere around 40 or 50 units you need to split it. The largest insulin syringe contains 100 units. So I split it anywhere between 50 and 100, depending on kind of my discharge plan, and if I'm going to stick with once a day versus twice a day at home. That's when I split it.
Haven't you done that in the past on people that are somewhat non-compliant too?
They're like on 12 units of Lantus, and you're hoping they would get at least one of the 2 shots in.
Yes, that's another effective method. Hedge. Yeah, and I do it for patients who are on really high insulin drip requirements. Okay, that their weight and their home dose that has proven to be effective. That there's this huge gray cloud of infection, insulin resistance. I'll tend to split so that I can go up or down faster than just every 24 hours. Hedging.
Kind of back to the volume amount.
Mm-hmm.
So back to the U500. So you're switching to U100. How much volume would you give sub-Q in one spot versus having injected in 2 different spots? You know what I mean? Say if they're getting 3 mLs of this U100 because they're on 350 or something.
Mm-hmm. So I have a patient right now that takes U500 90 units TID. 90 units. So that's, and we have him on 35 BID of Lantus and 24 AC of Lispro. And his blood sugars are perfect. 1, we give it to him. 2, he doesn't drink juice and eat graham crackers all day long.
And no pint of ice cream overnight plus cookies. Just got that information.
He also has a BMI of 75.
Whoa.
So is there a max amount that you put in a sub-Q?
100.
For absorption?
Just 100 units.
Okay.
So, because that's the largest syringe. We've had patients here that are U500 patients that we've had to have on more than 100 BID, and then we'll TID it, their Lantus.